Hello everyone, my name is Hongyi. I'm a radiologist from the Second Affiliated Hospital of Shantou University Medical College. Welcome to the medical imaging class. Let me start with a case. This is a 91-year-old man presented with chest and back pain for 2 years, aggravated to a tearing pain for half an hour. He was admitted to the emergency room. Hypertension was found and an urgent chest X-ray was taken. What are the characteristics of the imaging finding? What other imaging studies should be done? What is the possible diagnosis? With this question in mind, let's start this section. These are the contents that we are going to talk about. There are 5 parts: pathogenesis and definition of aortic dissection, AD, causes and clinical features of AD, classification, diagnostic imaging, and finally, I will summarize the main points of this section. I hope that we can achieve the following learning objectives after this class. First, identify the pathogenesis and clinical manifestation. Second, recognize the typical diagnostic imaging and classification. What exactly is the meaning of aortic dissection? Aortic dissection is the most common form of the acute aortic syndrome and a type of arterial dissection. Before we recognize the aortic dissection, let's look at the anatomy of the aorta. The aortic wall is composed of 3 layers: the intima, media, and adventitia. Aortic dissection occurs when blood enters the medial layer of the aortic wall through a tear or penetrating ulcer in the intima and checks along the media, forming a second blood-filled channel within the wall. The dissociated intima divides the aortic lumen into true lumen and false lumen. As blood flows down the false lumen, it may cause secondary tears in the intima. Through these secondary tears, the blood can re-enter the true lumen. Aortic dissection can quickly lead to death from lack of blood flow to the heart or complete rupture of the aorta. Aortic dissection is associated with hypertension and could be the result of chest trauma. Most in the individuals who present with an aortic dissection have a previous history of hypertension. The other causes of aortic dissection are structural aortic abnormalities, Turner syndrome, and illicit drug use, and so on. Patients are often hypertensive, although they may be normotensive or hypotensive, and present with chest and back pain, often described as tearing in character. There may be a difference in blood pressure between 2 arms, depending on where the dissection occurs. The classification of aortic dissection is very important because it is the main criterion for clinicians to guide management. The most common classification systems of aortic dissection are DeBakey and Stanford. The DeBakey system is based on where the original intimal tear is located, and the extent of the dissection is divided into types 1, 2, and 3. Type 1 originates in ascending aorta and propagates at least through the aortic arch and often beyond it. Type 2 originates in and confined to the ascending aorta. Type 3 originates in the descending aorta and rarely extend proximally but will extend distally. The Stanford classification divides dissections into types A and B by the most proximal involvement. Type A affects ascending aorta and aortic arch, and possibly the descending aorta. The tear can originate in the ascending aorta or aortic arch. It includes DeBakey types 1 and 2. Stanford type B involves the descending aorta without the involvement of the ascending aorta. It includes DeBakey type 3. The Stanford classification is more commonly used in clinical practice, as type A ascending aortic dissections usually require surgery, whereas type B dissections generally are treated with medications, unless there are complications. How can we make the diagnosis of the aortic dissection? Some patients may be strongly suggestive of having an aortic dissection according to a good history, but the diagnosis cannot always be confirmed by history or physical exam alone. Often, the diagnosis is made by visualization of the intimal flap on a number of diagnostic images. These include chest film, computed tomography, CT, CT angiography, CTA, magnetic resonance imaging, MRI, MR angiography, MRA, and ultrasonography. CTA is the most common diagnostic image used in clinical practice. What's the reason? Let's take a look at the various diagnostic modes. Let's go back to the case presented at the beginning. The chest film shows a change in the morphology of the thoracic aorta. The widened mediastinum, enlarged aortic knob, and tracheal deviation can be seen. The findings are of moderate sensitivity in aortic dissection. There are other indirect associated radiography findings not shown in this case, including calcium site, which means inward displacement of calcified intima over 1 cm, pleural effusion, depression of the left main bronchus. However, the chest film findings are of low specificity, as many other conditions can cause similar changes. So, CT and CTA were taken to make the diagnosis. Let's look at the CT scan. Figure A shows a dilated descending aorta. Then CTA was taken to confirm the diagnosis. The actual CTA, figure B, shows that the low-density intimal flap, red arrow, divides the descending aorta into 2 lumens. Curved planar reformation, CPR, figure C, indicates Stanford type B aortic dissection, extending from the descending aorta to the upper abdominal aorta, with an interrupted intima in the descending aorta. These CT images are from another patient demonstrated Stanford type A aortic dissection. Curved planar reformation, figure A, and 3D reconstructed image, figure B, show the aortic dissection extending from the ascending aorta to the upper abdominal aorta. The actual CTA, figure CD, shows a tall, low-density intimal flap, red arrowed, in the ascending aorta and 2 lumens of the aorta, green arrow. The density of the fourth lumen is usually lower than the true lumen because of flow velocity differences. The flow velocity of the contrast in the true lumen is faster than in the fourth lumen, resulting in bright white true lumen and gray fourth lumen. CT, especially CTA, is the investigation of choice, is able not only to diagnose and classify the dissection, but also to evaluate distal complications. Its reported sensitivity and specificity are nearly 100%. Let's summarize the CT image features of aortic dissection. Non-contrast CT may demonstrate only subtle findings. However, displacement of intimal calcification into the lumen is often visible. A high-density neurohematoma is also a frequent finding. When aortic rupture happens, a high-density hematoma can be seen around the aorta. CT angiography can clearly indicate not only the low-density intimal flap, which divides the aorta into two lumens, including the true and false lumen, but also the ruptured intimal flap. Other ways to diagnose aortic dissection include MRI and MR angiography, MRA, for their non-invasive nature. But the disadvantage, including high cost and difficulty with compliance in certain patients, limit its use. MRA is the most frequently used MRI sequence. In MRA, Figure A, the intimal flap is visible as a dark linear image between true and false lumen. Differences in flow velocity displayed a high signal intensity white in the true lumen compared with the low signal intensity grade in the false lumen. The imagery findings are similar with CTA. What are the characteristics of aortic dissection in routine MRI? The axial ECG-gated spin echo image, Figure B, showing type B dissection with the dissection flap clearly outlined in the ascending aorta arrow, showing persisting false lumens curve arrow above the ascending aorta. The configuration of the descending aorta is less clear with variable signal, suggesting either slumbers or slow flow in the false lumen. The advantage of ultrasonography is relatively low cost, availability, and non-invasive nature. An ultrasound can display the true lumen and false lumen of an aortic dissection separated by light linear intimal flap. The color flow during ventricular systole suggests that the upper lumen is the true lumen. However, bone and air in the chest limit the use of ultrasound to assess thoracic aortic dissection. It also cannot reliably identify the presence of the proximal and distal extent of the dissection. Let's summarize the main contents of this class. Aortic dissection occurs when a tall intimal allows blood to flow between the layers of the aortic wall, forcing the layers apart. CTA is the best diagnostic imaging of aortic dissection, and the typical signs include intimal flap, double lumen, and ruptured intima. The debated classification, along with Stanford classification, are used to separate aortic dissection into those that need surgical repair and those that can be managed conservatively. That's all for today. Thank you for your listening.